Good morning. I'd like to welcome all of you early birds to our annual conference on medical ethics. And we have a jam-packed day today, so I want to get us started. We are being welcomed first by our Dean, Dean Dennis Charney. Thank you very much for being here, and we'll get the day underway.
Thank you. So, I was just talking, to me, the term learning healthcare system is actually a pretty new term, but we do it. And in fact, that has become an important part of how we are combining the expertise of our school, where we have invested a lot in data science and predictive models as it relates to disease, genetics, is a major part of our school. We spun out a company, recently Semaphore, and now we will be essentially building a new building. We're doing a gut renovation of a building that is just 1 block north of where we are, starting in September, and it's going to be the James Family Center for Artificial Intelligence and Human Health. And in that center will be many new researchers coming to Mount Sinai, but also bringing together teams, some of which are in this room or will be coming today, that will work together with our data scientists, our geneticists, to enable our health system, Mount Sinai Hospital and all the other hospitals that are part of our system, the hundreds of ambulatory sites, the 2 million plus patients that we take care of, to have a learning health environment that enables us to improve the way we prevent, diagnose, and treat human disease. I hope what comes out of this conference is new ideas for us on what we ought to be doing together, what kind of teams we should be putting together, what kind of investments our health system and our medical school should make right now so we have a truly learning health system. So thank you for those who have come from far away. And thank you to our team that's going to be presenting over this day. So thank you, and I think David Rich, the president of Mount Sinai Hospital, is next.
My history: I've been here at Mount Sinai 35 years as of June 30th. That's the day I showed up for orientation, and I've watched the place evolve over time. And what has happened with the meteoric rise of our school and the creation of a health system is we're somewhat unique in that we're not part of a larger university. We're completely devoted to healthcare. And having one school and now 8 campuses provides an environment which is a perfect one to truly accelerate what is going on in medicine today. One of the, I won't claim this as an original thought. I did read this from a healthcare consultant, but if we think about what the platform is for healthcare going forward, it is a combination probably of 3 major things, since I love to oversimplify. And the first is fairly obvious, that we have to focus on population health, that focusing obviously on curing disease rather than waiting for diseases to progress is a very important part of medicine. But 2 other major components really come into that. One is that we have in our platform a way to completely bring together all of the information in a way that has never been there before. And that's the essence of what this health system is. So let's not call it artificial intelligence. A lot of people like to use the term augmented intelligence. And the reason we want to say that is it's somewhat insulting to healthcare professionals to think that just a machine could replace you just like that. But creating systems that bring us to a level where we deliver healthcare in a much more effective fashion and account for our failings as humans, but also accounting for the failings of machines, creates a better environment where we can create the health system of the future. And so if we think about it, going back again, since we'll go to those 3 concepts, it's population health, which creates the access to the healthcare system. It's the electronic records that bring us all together, the platform of having the data in an environment where it's accessible. And finally, it's taking that massive amount of data and information and turning it into knowledge which is actionable. And the reason we're here at a bioethics conference, as I see it, is not just because Rosamond is a brilliant bioethicist and a great colleague and attracts great talent and colleagues from all over the world. It's because we're thinking a lot about what this means. I've had long discussions as I've done work earlier in my career with Glenn Martin, who's head of our Institutional Review Board. He'll be speaking later today about what are the ethics that underlie what we're doing. As we change our healthcare system, to what extent are we informing patients about the ways that we're changing it? And have we made our patients partners in this process? So I think that this constellation of things where Mount Sinai feels that we can really change the world in a positive way also confronts us with the conundrum of how do we do it in a way which really is not done sort of behind the scenes and only with, let's say, some people have very commercial aspirations of what would happen as they develop AI and applications to medicine. How do we make it a holistic whole where we consider what we're here to do, which is to be the greater good of society, helping our patients, and how can places like Mount Sinai, since all of us come from all over the country and all over the world, how can we come together as a community of academics and do it in a way which truly addresses the needs of our populations? So thank you very much for allowing me to say a few introductory comments. And I think, Robbie, are you going to make some comments? David's making comments next. Dean Muller, our Dean for Medical Education, will be making some introductory comments.
So I'm going to be very brief, and then I have the pleasure of facilitating the first panel. I do also want to welcome everyone. I think probably everyone has the program for the day. I want to point out that in very small font on the back it says 28th New York Regional Conference, 28 years of sustained symposia that Rosamond and her team have been putting on. A really impressive feat. And last month I had the privilege of attending her international consortium on bioethics, which just is always a phenomenal conference. Next year is taking place here at Mount Sinai. And so I want to acknowledge not only Rosamond, her team, Karen Smalls, Paul, partnership with Robbie Freeman, in creating this day and all of the work they've done over the last decades in exploring much more broadly and deeply the things that we innovate. And then the other perspective I wanted to add to what was already said is from my role as Dean for Medical Education. The work that's being done here now is generating enormous interests from people who are on the applicant pool coming to the healthcare workforce. People who in the past had backgrounds in things like computer science and engineering, math, physics, and never really dreamed of marrying that to a career in medicine. And now that is the most exciting thing people can think of doing as they ponder the possibility of becoming physicians. And some of the folks here, in particular Eric Orman, but others have actually reached out into our applicant pool and have worked with some students before they even arrive at Mount Sinai and have really done some exciting things. So our future looks good. So Avniel Satrit Klein is the first speaker. There you are. Sorry, I thought you were on the other side. Welcome. And I'm not going to spend a lot of time in introductions. Everyone's bio is a little bit in the handout, so go for it.
All right. Thank you. I don't think I've been at this podium since around 2011 when I demoed Epic for the group, so it's nice to be back here. Thank you to Robbie and to Dr. Rhodes for inviting me. I've been working with Robbie for the better part of the last decade on implementing really impressive initiatives that his team has come up with. And I have fond memories over the years of being educated by Dr. Rhodes and recalling the ethical conundrums inherent in sharing a pot of spaghetti and how that relates to distributing ICU beds. If you don't know about that, you should ask her at some point. It's fascinating. I guess all the presentations are in this folder. And is that the first or the second? That looks like the right one. While the 2010 version of PowerPoint loads, my name is Avni Klein. I work in rehabilitation medicine, specializing in neurorehabilitation, and since around 2010 have worked with the clinical informatics team and currently serve as associate CMIO, which gives me a lot of touch points and some responsibility for the ways in which the various computer systems and technology that we use touch our patients and clinicians. So let's get down to it. So IOM set up a definition of the learning healthcare system, and this seems like a pretty good slide to start the conference with what is the learning healthcare system. The definition is somewhat longer than this, but I pulled out what I felt were sort of the two key bullet points, which are learning healthcare system is a healthcare system in which the best practices are seamlessly embedded in the delivery process, and new knowledge is captured as a byproduct of that delivery process. So there is feedback to the system which improves the system and which helps to personalize the system as it moves forward. I don't have a lot of fancy graphics in my talk. This is the most graphic intensive slide that we have, but I also don't have a lot of tables and figures to bore you with, so it's a trade-off. So this is kind of a graphical representation of what a learning healthcare system could be. Down at the bottom, you have the doctor with the blue arrow being the delivery process, or the delivery system, and as you see, it sort of passes through a computer. This has been the case in many places for many years, decades. We've been using computers to help deliver healthcare here at Mount Sinai since at the late 90s, early 2000s, at least in terms of the front-facing systems. Many of those early systems were very one-way sort of things. You could use it to place orders. Those orders would get communicated to the pharmacy or to the laboratory. But that was more or less the essence of it. They didn't present a lot of guidance, a lot of information. They weren't data repositories about the patient. And what we have now is sort of a whole support system of research scientists, of data scientists, of innovators, informaticists, all of whom are coming up with methods and ideas of how to improve the patient care and contribute that to the computer systems that are used along the delivery process. And at the same time, the electronic systems that we're using now can give information back to this research scientist informatics community to advise and to be the tools with which they produce that innovation. So the key of the healthcare system is this sort of two-way pathway between the technology, the data community, and informs the delivery pathway with which the doctors talk to the patients. So where I come in is sort of to answer the question of, you're going to hear a lot from other people who've been doing far more innovative stuff than I have about the new systems that they've developed, the new technologies, the machine learning, the artificial or augmented intelligence, all of the really cool buzzwords. We're doing all of that here. But all of that happens away, in a sense, from the clinicians and the patients and can't really help anybody unless you get it in front of the clinicians and to the patients. And sort of the place in which that happens, as we have it set up, is the electronic healthcare system. Similarly, these folks can't address any particular patient's problems without the data about the patients, and that also is coming from, right now, the electronic health records that are capturing, storing, and delivering that information. So the question of how to operationalize a learning healthcare system, how to get all those great ideas to actually turn into some patient value, how do we get our best practices in front of the clinicians? And moreover, how do we get them to follow those best practices? Which really comes down to how do we influence clinician behavior? Which for all the ethicists in the room, you can file that question away over the course of the day, which impacts things like paternalism and autonomy and coercion to some degree if we're trying to force decision-making in some way, and all leads to the big question of beneficence that underlies our profession of trying to do things that are in the patient's best interest and minimize the risk of harm that sometimes can be attendant with trying to implement automatic and machine-based processes. So the answer to how generally falls under the general category of what's called clinical decision support, which is a nice term. It sounds beneficial, it's supportive, it's friendly, and it's classically broken into two main categories. There's passive clinical decision support, which is the information is there for you. Reference material, taking a textbook from the library and putting that textbook on the desktops of the computers that the clinicians use as an electronic searchable reference, that already is a form of clinical decision support. Now when you're doing your work as a clinician, you have a way to get more information about how to take care of your patients. Taking that reference material out of the library, putting it on a desktop is one step. Taking it off of just the desktop of the computer and putting it directly into the electronic ordering system as a drop-down menu of topics, that's even further decision support because it brings the reference material, it brings the information closer to the delivery pathway. Order sets. Early clinical systems, all of the orders were there, but it was just a big flat database of orders. You had to decide, what am I going to order for this particular patient? 10 different clinicians might order 10 different things for the same issue, same concern, just based on what their familiarity is with. Order sets allow you to categorize groups of orders under a topic. So you can collaborate with pulmonologists and infectious disease specialists and come up with an order set for pneumonia, and that will already be providing guidance. Rather than, how should I treat this pneumonia? I'll pick an antibiotic. You have a list of, here's a choice for community-acquired pneumonia, here's a recommended antibiotic based on our particular system for hospital-acquired pneumonia. Here are the recommended tests to order, etc. So order sets are a form of passive clinical decision support. Note templates can be a form of decision support. Again, rather than having people document sort of as they wish, some notes being better than others, just depending on the person, a note template can guide the process of documentation, ensuring that the appropriate information is gathered for each patient. So passive clinical decision support, it's there. You can use it, you can not use it. You generally have to go and seek it to some degree in order to get it. Active decision support, on the other hand, are things like the classical example of active decision support are alerts, things that pop up when you're doing your workflow, interrupt your workflow and say, hey, there's something that I want you to think about, there's something I want you to consider doing differently than what you are about to do. And we'll talk, most of this, my introductory talk is going to be about those sorts of active decision supports and what the pros and cons of interrupting your workflow and trying to get you to change what you're doing by giving you information at that point. Order sets and reference material showed up in my passive list, so why are they there too? Is because, like in most things, a black and white breakdown of passive and active isn't necessarily 100% active, and there could be, as we get more sophisticated, more of a continuum from passive to active clinical decision support. If an order set, rather than being, already an order set, like I said, is clinical decision support, but if you now look at the patient characteristics and say, wait a second, this patient has came in with a diagnosis of pneumonia or has a fever, has respiratory issues, maybe I will have the computer suggest these 3 order sets for you rather than allowing you rather than expecting you to go and find the right order set on your own. I will look at the patient's characteristics and I will suggest an order set for you. I'll look at the demographics and suggest a pediatric pneumonia order set. I'll suggest a geriatric pneumonia order set. And in that way, order sets become a more active form of decision support and fit more into the paradigm of a learning healthcare system because now they're taking information from the health record, applying rules to it, and then feeding back best practices to the clinicians. Similarly, rather than having just a textbook hidden or not hidden, having a textbook up in the menu system where right now we could look things up in up to date while we're, I'm going to take care of a patient for a leg fracture, but he also happens to have myelodysplastic syndrome. I could very quickly look up what the current thinking and best practices are for myelodysplastic system by dropping it down. A more active system would be one that looks in my patient's medical history and maybe has a sidebar of educational topics selected for that patient based on the patient's characteristics. So again, what we're going to talk more about is the alerts, and that, rather than the guidance just being there when you want it, is the system really jumping in a little bit more actively and trying to get you to do something different. So coming back to the learning healthcare system and applying where clinical decision support fits in, basically that community of brilliant people is the CDS engine, the people who set up what the rules and triggers are for presenting information, presenting alerts to the healthcare system are, and pulling from the healthcare system things like patient data and even being able to pull the outcomes out of the healthcare system and looking. In theory, you could have machine learning or augmented intelligence take a look and see, we've been using this medication for this condition in all of these patients. You can pull the outcomes. How did those patients do? Did the fevers go down in the appropriate amount of time? And the data science folks can fine-tune the rules and triggers that feed into the healthcare system based on that. So some examples. If you're looking to interrupt someone's workflow and change their behavior with clinical decision support, the ideal system is one in which those types of intrusive alerts are reserved for the action that you're about to take might harm the patient, right? Clinicians typically don't want to harm the patient, and an alert like that is appreciated and is listened to. For example, allergy warnings. If the system knows that a patient is allergic to some component, it can cross-reference that with, hopefully, certainly with the formulary from the pharmacy to let you know that you've ordered a medication that might conflict with the patient's allergy profile, but even being able to say that the diet that you ordered has 3 things on it that are not compatible with the patient's allergies. Similarly, drug-drug interactions. I think that's obvious. It can currently, polypharmacy has been an issue for years, but we're still in a situation where patients can be prescribed easily over a dozen medications while they're in the hospital. For clinicians to keep track of which medication goes with which one is asking for mistakes, and having a system to bring out drug-drug interactions is important. To think about sort of how automatic do you want these systems to be? Do you want them to prevent you from ordering a medication if there's a drug-drug interaction? What level of interaction are you referring to? The databases are generally extremely conservative. If you order both Colace and Senna, which are both laxatives but work in different ways and can be both useful for a patient, you might get an alert that says, patient is already on a laxative, are you sure you want to order this laxative as well? And 99% of the time the answer is going to be yes. It becomes a challenge for the clinical community to figure out what level of alerting do you want to show to people so that they don't get in the habit of quickly dismissing alerts. That's what is called alert fatigue. Once people get used to dismissing alerts because you're showing them too many alerts that don't really impact the patient significantly, then there's a much higher chance that they're going to do the same quick dismissal of an alert that might really be important for the patient. I recall, you know what, I think it's still, the funny thing that I can't even recall if it's still the case is exemplifies the situation. But certainly in one of our older systems, every time you open the system, a box came up that said you are about to access, I'm pretty sure it still comes up, you are about to access medically sensitive information. This access is meant to be viewed only by the appropriate people and may not be shared. Failure to do this will result in disciplinary action up to and including dismissal. I had asked, this was a couple of years back, I asked a sampling of people if they had noticed a box come up when they opened the medical record system and what that box said. A few people did notice the box come up. Nobody was able to tell me what was in the box. The box appears on the same place of the screen every time, so the OK button for that box is at the same XY coordinates on the screen, really no matter what, and the muscle memory from a neuro rehab perspective is kind of fascinating, but the muscle memory to close that box is so fast that there's no conscious input of the information before you get on to what you actually want to do. And so that's an example of interrupting someone from trying to get to where they want to go really just trains them to get around the interruption, more so than changing their behavior. Other examples of good and well-meaning alerts, alerts for you're ordering an MRI, but a patient has a metallic implant. We have something like that installed. Alerts for your patient's potassium level is extremely high, and suggestions, therefore, within the alerting system of orders that you may wish to place, actions that you should take. And sepsis was a big initiative that we took on several years ago because it's something that's, on the one hand, ideal for computers to try to address because the diagnosis of sepsis relies on the realization that a number of different factors are simultaneously going in the wrong direction. And that happens often not all of a sudden, but sort of gradually over time. And the computer's ability to pick up on those trends and notice it before you can lead to intervention happening hours earlier than it otherwise would, and those hours translate directly into decreased morbidity and lives saved. Excuse me. But all of the systems that we talked about, both in terms of the decisions of what sort of thresholds you want to draw, like in the drug-drug interaction example, rely on the completeness of the information and the correctness of the information in the medical record. Right, that arrow going up to the data community coming from the medical record. If you've got MRI and implant alerts, well, how does the computer know that there's an implant in the first place? Someone has to enter into the medical history that this patient has an implant, and then the alert can use that information to trigger a warning if you order an MRI. If you become reliant on a system like that, then if someone neglects to enter that information, if someone comes in because of a brain injury and they're not conscious or competent, they don't have family with them, there's not the information, maybe nobody elicited that information during the intake process and they're rushed off for an MRI, the computer will not alert it, and if you rely on a system like that, then things can be missed and the patient can be put at harm. Similarly, sepsis triggers, right? It's, again, not a black and white sort of thing. We try to work on a system where, 80-20 rules apply, and for most of the time the system will be correct. I work on a unit with a lot of patients with spinal cord injury. Their blood pressure drops as a result of autonomic changes due to their condition, and they get a lot more of these sepsis alerts because they have low blood pressure, which is one of the triggers. If they are working in the therapy gym and their heart rate goes up while their blood pressure is still low, that's a trigger for a sepsis alert. And again, you can run the risk of alert fatigue of, this patient has triggered sepsis 20 times, it's never been sepsis. The time that it is sepsis can be missed. So there are dilemmas in how to design this. The alerts are powerful, they're attractive, because you want to do something. We have a system that's a really great system here at Mount Sinai of doing root cause analyses whenever there is either actual or even a near miss of patient harm. And the root cause analysis is supposed to lead to a corrective action plan. There's a schematic that's looked at when every correction action plan is made of different types of interventions and what the strengths of those interventions are. So a lot of times education is suggested as an intervention. So-and-so didn't do the right thing. We need to re-educate the people to do that. Education is a very low yield sort of intervention. It works really well when you give the education. A couple of weeks to months later, that education goes away. When the new crop of people come in, unless that education is institutionalized, they don't get that education. So a more permanent change, such as a change to the electronic medical record system, is considered a high yield and high effect intervention. So whenever something almost goes wrong, alerts in the system are often looked at to answer the problem. And in a sense, they can get overused, leading to the alert fatigue and issues that we spoke about. And alerts are not always the most appropriate tool. The key, there are 5 rights to clinical decision support. I don't love all 5 of them, but 3 of them are delivering the right information to the right person at the right time. And that's also the key to changing behavior. And I'm going to go straight to the examples to show the difference. People, again, because we know about that alerts exist, the alerts don't only get used for you are about to do harm to the patient, you need to stop. The alerts are also, we also get asked for alerts for things like, that are important for patient care, improving the quality and regulatory compliance of a system. So years ago, we were asked for an alert to warn folks about chronic kidney disease. Not to take a clinical intervention because the patient has chronic kidney disease, but to add chronic kidney disease to the problem list in the medical record, mostly so that it can get coded, get included in the notes, so that the medical coders can include it into the list of diagnosis that the patient is hospitalized for, which then leads to a different diagnostic reimbursement category and changes the reimbursement for care for that patient. That's crucial for keeping a healthcare system going. If we're taking care of patients who require more resources and who are sicker, then we need an accurate list of their diagnosis to be able to keep that system going with the appropriate reimbursements. Putting the chronic kidney disease on the problem list also enables a whole slew of additional clinical decision support, different drug warnings, different dosages because of kidney disease, and yields a lot of benefit down the road. But if someone hasn't already put chronic kidney disease on the problem list in the first place, how do you get them to do that by popping up an alert that says, your patient may have chronic kidney disease, please enter it onto the problem list? Chances are, and not only chances, it's almost 100% guaranteed that whoever opened the medical record at that time was not doing it for the purpose of entering chronic kidney disease on the problem list. If they were going to do that, they would have done that already, and you wouldn't be in this situation. They were going into the medical record to do something else. They were going in there to order a head CT. They were doing that because the patient can't sleep and they need to order some trazodone. They were doing that to enter their daily note. Now you're stopping them and saying, hey, could you check and see if they might have chronic kidney disease and enter that? They've got to file that now kind of into their head and say, all right, let me see if I can get back to that. Or they have to file away ordering the head CT and whether it's going to have contrast or not, and do they need some pre-medication. They have to put that aside and go and think about the kidney issues. And either way, there's either a risk that they're just going to dismiss the kidney disease alert and not get to it, or they're going to have a risk of delaying that head CAT scan or not do that in the correct way. Similarly, we have alerts because there are regulatory reasons that we want people to have an order explaining why the patient needs a Foley catheter on a day-to-day basis. So there's an alert that says your patient has a Foley catheter, please place an order for it. Again, not what you went into the system to do in the first place, and changing what you're doing. A different category of dilemma kind of comes to the thinking about all of the triggers and all of the exclusions that you might need when you're setting up an alert. So if a patient is on 2 different anticoagulants, we want to warn you of that fact because double ordering an anticoagulant leads to increased bleeding risk and can have increased morbidity. If a patient just ruled in for an MI and you're putting them on aspirin and Plavix, should that alert come up? What about heparin and Plavix? Should that alert come up? We do have it set up to do that, which has been shown. Nick Jeans provided some information, I think, that's been published that seeing that alert in the emergency room delays the initiation of the anticoagulation therapy as the clinicians stop and think, wait a minute, does that apply to my patient? Am I supposed to be doing that right now? And the answer, of course, is, well, no, you've got to make them exceptions to the rule. But when it comes down to it, everyone who has a child under the age of 10 knows that if you set up rules, you're going to have a whole lot of exceptions and people who want exceptions to those rules, and that makes getting the proper design difficult.
About 3 minutes left.
Great. This is the last slide. So how do we try to get around these issues? So there's a clinical decision support governance structure that tries to really get all of the information up front about what it is that you want to do. People come to us all the time saying, we need an X. We need a hard stop here. We need an alert here. We need something. And the best thing that we can do is take them back 2 steps and say, what is it that you're trying to do? More so than what is it that you think you need, and figure out what's the most appropriate way to get to that. For example, if either the chronic kidney disease or the Foley catheter situation, what they want to do is get good documentation. What they want to do is achieve regulatory compliance. Maybe the clinician isn't the right person to do that. Maybe it's a case manager. Maybe it's a medical director. Maybe the right answer, since this isn't an urgent problem, is to create reporting solutions. Using the same sort of clinical decision support technology that would drive the alert, the same triggers that would pull that patient into that population can put that patient on a list or on a dashboard or on something where the information is still readily accessible, but then can be worked by the appropriate person at the appropriate time with better outcomes. So we help guide people towards getting the right tool. We have multidisciplinary teams, nurses and pharmacists and compliance specialists to look at these requests and try to get them to the right place. Another factor is when someone does want alerting put in the system, it's so much easier to put something in than it is to take it out. And so we have to set the expectations at the beginning that if you're putting something in, there must be a result that you're trying to drive. Well, when do you expect to see those results? And we try to enforce collection of the data to show, did the intervention that you asked us to do achieve what you wanted it to achieve? Expiration dates for these alerts to revisit the question. If it's working, great. If it's not, we're going to take it out and let's go back to the drawing board on that. Finally, you could also set up these systems and then run them in the background before you actually put it out to the clinicians to see how many patients would this fire on? How many patients would it have helped versus how many of these would have been considered false alarms? And in that way, try to get to a system where in fact you can guide clinicians' behavior towards improving patient care. Done.
Perfect. Thank you.
So good morning, everybody. My name's Scott Friedman. I'm the Chief of Liver Diseases and the Dean for Therapeutic Discovery. And I was honored when Rosamund asked me to give this talk, and actually enjoyed a great deal thinking about it and working with her to touch on key issues. I'm also only the 3rd Division Chief in the history of Mount Sinai, which extends for liver back to the early 1960s. And we have a long and a proud tradition of excellence in liver research and care. So what I want to do is, in the next 15 minutes or so, introduce to you the convergence of how some of the challenges, ethical and otherwise, in clinical care in patients with liver disease, and how that intersects and sometimes benefits from what's called preclinical or animal research, and what are some of the ethical issues that are brought to the fore around that. So just to introduce some general concepts, this is not a scientific talk, but I do want to frame the challenges that we face clinically. Scarring or fibrosis of many different organs can lead to severe consequences, and this is from a review article actually from my very first fellow, Don Rocky, who's now the chair of medicine at Medical University of South Carolina, illustrating how many different organs can suffer from scarring conditions. And of course, in liver disease, we're most concerned about the scarring that occurs in the liver, which leads to an end-stage condition known as cirrhosis, which has a number of complications you see listed here. Liver has some unique I would say, capacities that make scarring a very protracted process that occurs over decades, particularly patients, as I'll show you in a second, with viral hepatitis. But ultimately, it can culminate in cirrhosis, and of great concern is the risk that cirrhosis imposes on the emergence of hepatocellular carcinoma. I'm proud to say we also have the largest liver cancer or hepatocellular carcinoma program in the United States, so we confront these challenges on the front lines every day. Hepatocellular carcinoma is the fastest rising cancer incidence in the United States, and it's the third leading cause of cancer mortality worldwide. We have a very, I would say, strong interdisciplinary program here to attack this problem. We also have a world-class liver transplant program, which in selected patients can rescue either patients with end-stage liver disease or even patients who have a very localized cancer that's amenable to taking out the entire liver and replacing it in transplantation. There are a couple of diseases where the process can sort of bypass the long scarring and develop a cancer straight away. I'll tell you a little bit more about it, but primarily hepatitis B virus, which worldwide affects almost 1 billion patients, and a new disease that's become actually the most compelling risk for liver failure in the 21st century, non-alcoholic steatohepatitis. So just to put a fine point on that, the scarring that occurs in liver is really a healing response of sorts. It's gone awry because you have many tissues, many insults to the liver that you see listed here that ultimately lead to chronic inflammation and scarring. And as I mentioned, non-alcoholic steatohepatitis has become a major threat to the health of our population here in the United States, but also in Europe and actually in the developing world as well. Our work has really tried to understand where that scar comes from. And what you see here is a diagram of a normal liver, and it points out a specialized cell type that I became interested in while a fellow at UCSF in 1983. And we developed methods to isolate this cell. It's called a stellate cell. It lives in the normal liver, and it has some unique features, including the fact that the body's storage of vitamin A is primarily in this cell type. And we exploited that property to develop for the first time a method to isolate these cells and grow them in culture, and thereby open the door to understanding better how scarring occurs in our patients. Now, I mentioned NASH. NASH is part of a larger umbrella term called non-alcoholic fatty liver disease, and it's comprised of 3 different stages. Some patients will progress beyond fat, and this is in association with patients who have the so-called metabolic syndrome. So as you're probably aware, and as I'll show you in a minute, the prevalence of obesity in this country has been rising for the last 30 years, and that imposes other health risks like diabetes, hypertension, hyperlipidemia, and also, as it turns out, liver problems. Usually they're overlooked because the liver when it's injured, has no symptoms, and yet in about a quarter of the patients who have fat in their liver, it may progress to an inflammatory state that represents a risk for further progression to cirrhosis and hepatocellular carcinoma, as I told you previously. And so we're beginning to tackle this in a major way in identifying patients and working with other specialists, in particular diabetologists, bariatric surgeons, who are seeing a lot of these overweight patients who don't know that they have liver disease. And so our challenge is to seek these patients. And one of the ethical implications of that is we're seeking patients with a condition that they don't know they have and for which there are no approved therapies yet. And so until we have approved therapies, we're in this kind of gray zone where screening and uncovering this disease can lead to a lot of anxiety and a lot of concern with no actionable information apart from the important but rarely successful advice of telling patients to lose weight and exercise. So this is a map of the obesity rates in the United States from 2014. And the colors indicate the prevalence or the percentage of that state population that is obese. Body mass index of over 30, normal is up to 25 in America. So, for example, states that have the purple color have 35% or more of their population is classified as obese. What you can see is that this is, I guess you would say, the obesity dense states here in purple, red next, orange, and then interestingly yellow is Colorado and California and Hawaii. So this is a pervasive problem throughout the United States, and right now, it's estimated that 65 million Americans already have this overall condition of fat in the liver that will rise to 100 million by 2030. That's at least 16.5 million now have this more worrisome stage of non-alcoholic steatohepatitis, and this too will rise to 27 million. And as I mentioned, we're deeply concerned about the risk of hepatocellular carcinoma. And screening guidelines, we're trying to yield new information in our studies to understand better who should be screened for this cancer, because in a simple statement, the only hope of cure for liver cancer is catching it early and either taking it out surgically, ablating it, or even doing the liver transplantation, as I told you. So both in liver research and care, there are really a number of different issues that have ethical implications. I'm not going to go through all of these. Most of them, and perhaps the most challenging, are around number 5 here, liver transplantation. But I will focus on animal models and liver disease research, because this is a generic or an important issue and an important stepping stone to developing new therapies for virtually all diseases. But most of our patients have either viral hepatitis, alcoholic liver disease, which has its own ethical implications, fatty liver disease, liver transplantation, as I mentioned, has major ethical issues that could take a whole day's symposium talking about donor availability, access to care, paying for the care, geographic distribution. The issues are numerous, and they're extremely challenging and very contentious. And finally, we shouldn't overlook the issues around costs of medication and who pays for that, because as I'll tell you, drug development is viewed as a very expensive enterprise, and there's clearly, I would say, a simmering tension always between the costs of generating new drugs and the cost to the patient or the payer. So let me tackle the issue of animal models and raise questions that I'm not going to try to answer in any meaningful way, but really just food for thought. And the simple question is the use of animal models ever justified? And if so, which animals? And these are the animals, species that have actually yielded advances in understanding and treating liver disease. So it's not a trivial question. Certainly rats, mice, but also pigs, particularly in transplant research, dogs in transplant research, and I'll get back to that in a second. But chimpanzees, I think, are now banned from animal research, and most of us think that's a wise choice, but it is worth stating that actually chimps were absolutely instrumental in discovering the hepatitis C virus, and with that discovery in 1989 came blood tests to screen and prevent, and ultimately, many years later, curative therapies. None of that would have happened, or at least not in the same way, had we not had chimpanzees. Our founding directors of the transplant program here actually learned to do transplantation surgically on dogs. Was that appropriate? I think most of us now would say no. Dog research is also increasingly frowned upon, and always there needs to be an effort to find out if there are alternative methods. And particularly now, and I guess Eric might speak to this, with virtual reality and artificial intelligence methods, maybe we can supplant the need for animals altogether by using these modern techniques. More recently, there are fantastic advances in understanding the immune system such that we can actually we're almost at the point where pigs can be raised with enough human genes so that if you were to take that pig organ out, you could transplant it in a human and not run the risk of rejection because it's a so-called humanized pig. That also has major clinical and ethical implications. So I just raise these as the things we are thinking about on the research side. And this is just to show you that the path of success for a cure of hepatitis C relied on chimpanzees. These are the major scientific breakthroughs, but if you look in the first box on the left, it was the discovery or the infectivity of this so-called non-A, non-B hepatitis that was only in chimps and non-human primates. We couldn't grow or infect animals of neither pigs, dogs, nor rodents, and so it was only the fact that investigators at the NIH and the CDC could actually take what they thought was infected blood, inoculate a chimp, and look at their response. So again, challenging issues, and with that major discovery over a 25-year period came the emergence in 2014 of the first all-oral regimen, which is now curative in 95% or more of patients with hepatitis C. And that leads to other ethical questions about, now that we have a cure for everybody, how do we identify patients who don't know they have it? who should pay for their drugs. That was a major issue when these new drugs came out. I'm proud to say also that Dr. Reich and his team have been extremely supportive of our efforts to go out and screen, particularly in high-risk communities, because screening and linking to care is curing not only hepatitis C, but preventing the emergence of cirrhosis and liver cancer. And so, as always, an ounce of prevention is worth a pound of cure. I want to also tell you about some of the other animal work we've done. This is work that was done in my laboratory starting in 2003 with a small company. Full disclosure, after we conducted these research contract studies, I became a consultant for the company. But what they were testing was a drug that they thought might work in cirrhosis, and so we used an animal model in which we could induce cirrhosis. This is what it looks like in a rat. This is the scarring staining. This is what the animal's liver looked like if it had been treated with this drug. And you can see on the microscope, the scar bands here are almost completely disappeared. So the company took this information, they went to the FDA, and they filed what's called an investigational new drug application, and that led over many years in studies I was not involved with to a clinical trial, because all of the benchmarks along the way suggested the drug was safe and it was effective. And one of the things that was very exciting is this was really the first time there was a doubling in the number of patients or percent of patients who had reduced fibrosis in response to the drug. So in many ways, this was a breakthrough. And the testing is continuing in humans. But the points I want to make really are what goes on behind this to conduct human studies like this. And it's almost a universe of extensive laboratory and animal testing to assess the activity, pharmacokinetics, safety, and dosing. This requires many different teams and specialized skill sets, both within academia, and I'm proud to say that Dean Charney has been highly supportive of many of these important pharmacologic elements that go into establishing whether a drug works and whether it's safe. And then, of course, critical studies that have to be done, testing in humans with informed consent. And as some of you may know, there's a fairly conventional approach to testing drugs. So-called phase 1 is in healthy volunteers to make sure the drug is safe. Safety, of course, always overrides everything in drug development. Then there are so-called phase 2 studies that are small studies in humans, but the humans or patients have to have the disease now, and we're starting to see, does this drug show any evidence that it's going to have an impact? And what's the right dose, and is it safe? And then finally, phase 2B or phase 3 studies are really the major studies that traditionally are used to establish if a drug is safe and effective in a larger population, and if a phase 3 trial is effective, companies will typically go to the FDA or to the European agency and seek approval. So it's a very long process, but overriding all this is, first of all, the safety, most importantly, and the unmet need, which I didn't really talk about much, but of course, drugs should only be developed where there's an unmet need. And then the issue of medications. Should human studies be designed for the purpose of reducing costs, for example? And this is actually, Rosamund got me thinking about this, because you could say that, let's say we have two drugs of equal potency, or let's say more challenging, you have drug A that's a little more potent but 10 times more expensive, drug B that's a little less potent but 1/10 the cost. Should we do studies to determine which one is a better value, if you will, which one is more efficacious? And these are the kinds of studies around the cost of medications that we have to really think about. This is also true for devices, also true for the cost of administrative oversight, and a number of other costs that go into establishing whether a drug is effective. So just to put a fine point on the long timeline and the challenges and the hurdles that go into drug development, this is a simple timeline that illustrates the number of years and the amount of money that's estimated to go into making a new drug. And so I'm hardly an apologist for drug companies. This is their claim, is that their costs of developing a drug are extensive. That's actually not always the case. And so I think it's a very legitimate question with regard to cost of medication and who should pay for it and who should establish the price. And who should have access to these drugs. These are really ongoing, very challenging issues, and they're going to only get more acute as the quality of treatments gets better and the cost continues to rise. So I just want to summarize 3 key points, and then we can address any of these in the question and answer in the panel. I think ethical issues confront liver researchers and physicians in a number of diseases and settings. I focused here mostly on the research aspects, and certainly in clinical care, liver disease has along with cancer, I would say, has some of the most challenging ethical questions. For example, should patients who have alcohol abuse be transplanted, and when, and should they be should they be made, or should they have the availability of living donor organs? So there's a long list, as I said, that I'm happy to address a little bit more in the panel. I would say drug development virtually always depends on animal testing first and then human testing. There are certainly exceptions to that rule, but we need to also confront how important and how dependent are we on animal models. Are new techniques available to us to circumvent the need for animal testing, particularly if it's a severe disease where we need to get better treatments to patients more quickly. And I think it's certainly axiomatic that establishing standards of research and care that are consistent and transparent is absolutely essential. And therein lies some of the challenges for us in academic medical center, particularly when we work with different stakeholders, both patients, providers, as well as payers and pharmaceutical companies. So I'll stop here, and I'm happy to take more questions in the panel. Thank you.
Thank you.
I guess to start by, I just wanted to thank Robbie and Rosamund for inviting me here. I spent 6 months studying deontological ethical theories with Edmund Pellegrino, and I still see that as being the most important 6 months of my medical training. And so I'm really excited to be at an ethics conference and to be in the presence of Professor Magnus. So by means of introduction, I'm Eric Orman. I'm an instructor of neurosurgery, a PGY6 resident, and the director of AI Sinai, which is our AI research group. And I'm going to talk a little bit about neurosurgery research in the learning healthcare system, but also machine learning research in the learning healthcare system, since that's a lot of what we focus on. I have some financial conflicts. And actually, I was thinking, Avneel's first slide I thought was pretty interesting about what a learning healthcare system is. It's a new term to me, but I think there's a lot of parallels with machine learning. So the definition of machine learning is, how do we learn algorithms by exposing equations to data? And in some ways, I feel like there's a parallel there with the learning healthcare system, where how do we learn medicine by exposing our healthcare system to patients? And so in some ways, to me, machine learning is the mathematics then, perhaps, of the learning healthcare system. And speaking of that patient information, for neurosurgery and neurosurgical research, I think there's 3 very important qualities to that information, which is true of all medical research, but particularly in neurosurgery. And one is that the data is costly. Neurosurgical operative procedures typically involve a lot of technology and expense, and a lot of our patients consume many days in the ICU. But also, a lot of neurosurgical outcomes are denoted by survival and by neurologic deficits. And so there's a very real human cost to neurosurgical data, and acquiring more endpoints in neurosurgical research often entails patient survival or neurologic injury. Neurosurgical information also tends to be sparse. A lot of our diseases are fairly rare compared to the rest of medicine, with incidences ranging in the 1 in 100,000 to 1 in 500,000 range. And so data-efficient methods are very important. And last but not least, neurosurgical outcomes involving neurologic function, it's sort of intrinsically high-dimensional. A lot of things can impact neurologic function beyond pure neurological processes, urinary tract infections, and so forth. And so dimensionality reduction techniques, again, are an important part of neurosurgical research. So one of the first major studies by our group was looking at predicting outcomes for patients with arteriovenous malformations, sort of aberrant tangles of blood vessels in the brain. And it's a fairly rare disease, about 1 in 100,000 patients. And so to do this kind of research, to address that sparsity of data, we had to form a collaboration with both the University of Virginia and the University of Pittsburgh. So we put together the largest cohort ever, about 1,800 patients, and compared machine learning methods at predicting outcomes to the standard techniques we use in neurosurgery, these various scoring systems. And we found that a sparse logistic regression, so there's a type of machine learning model that's designed to handle sparsity, actually works better than everything else that we do in neurosurgery. The other interesting aspect of approaching this with this machine learning technique specifically is that the sparsity constraint also lets us do feature selection, which is finding out exactly what accounts for that prediction. And so not only do we develop a better predictive model, but we also found that this marginal surface dose the amount of radiation dose delivered to the periphery of the AVM actually was the second most predictive component of the model. So we actually learned something new about the radiobiology of arteriovenous malformations potentially. Following up this theme of costly data, our next major focus was trying to find ways of making data less costly, and specifically of taking the radiology reports generated in the Mount Sinai Hospital and finding ways of extracting the diagnoses from them using natural language processing. Which, this is one of my favorite studies that we did, because we didn't just look at the radiology reports, we actually looked at a lot of just natural language text. So we studied Amazon.com pet reviews, Reuters news articles, English language novels, in part just to develop a feel for the actual language of medicine. And one of the interesting findings was that if we normalize everything against a Reuters news article, which is roughly like a 9th grade reading level, is what Reuters targets, 9th to 12th grade, that the radiology reports are significantly more straightforward, which is kind of what we want in a radiology report. A very clear, succinct description and clear language describing what diagnoses are. And kind of interestingly to us, medical discharge summaries was about 1.36 times as complicated as a Reuters news article and substantially more complicated than the radiology reports. As part of our real end game for this task, though, we wanted to develop a classifier for diagnoses, which we did. And we found that deep learning models, which is a type of machine learning technique, achieve this state-of-the-art performance on classifying or finding the diagnoses contained within radiology reports, about 96% accurate, which suddenly for us significantly decreases the cost of data. To get the data for this study, we had to build a crowdsourcing platform and have a collection of radiology and neurosurgery residents, about 60 hours a resident, go through the crowdsourcing platform to label all the studies. But now we have a deep learning model that can do that for us at cost. Another, in terms of the themes here of dimensionality, the way the deep learning model works is it takes all of the language in the radiology reports and it projects that into this 1,024 dimension space. We can take that space then and project it back into 2 dimensions, and you get this graph here. We can see the language automatically forms clusters based on the semantic content. So we have physician names, diseases, anatomical terms, and surgical procedures, which is a nice validation that we actually learned something meaningful from the language in our study. Using those reports then to get more at-cost labels, our follow-up study was to see if we could train an artificial neural network to detect hemorrhage, stroke, and hydrocephalus in head CTs. This is one of our initial motivating studies of our group because it's very near and dear to my practice of neurosurgery, but also this is very much kind of what artificial intelligence is about. Can we improve medical processes and deliver better care at cost? And in a randomized, double-blind controlled trial, we showed that using this tool to screen head CTs decreases the time to diagnosis, even though the diagnostic accuracy of the deep neural network is less than our human radiologists. So by focusing on the problem and finding ways of, rather than looking at how accurate the neural network was, but on whether it could bring scans to physician attention sooner, we actually still recognized a clinical benefit here in our randomized controlled trial. It also raised this interesting theoretical question, though. Why is this deep neural network, which we now have these positive RCT results, why isn't it as accurate as humans? And we honed in on this fact that we were actually doing weakly supervised object detection, which is a type of computer vision approach. But the key thing is that the idea is that rather than identifying whole images, for example, like cat photos, dog photos, we're trying to find things within the images, but only having the diagnoses for the whole images themselves. And so our follow-up study, we switched around and looked at pneumonia and chest x-rays, in part because we take so many chest x-rays within the Mount Sinai health system, and also we had access to them across our health system. So we really wanted to leverage the fact that Mount Sinai is this large, multi-center system. And what we found was that we could train a deep neural network again that could detect pneumonia with a very high accuracy. But when we drilled into the results, the reason why it was so accurate was because it was largely just guessing that chest x-rays coming out of the Mount Sinai hospital had pneumonia because our patients here tend to be sicker and tend to be intensive care units, while our outpatient practices tend to be normal because those are the populations. the deep neural network wasn't actually detecting pneumonia. It was detecting where the scans were getting taken. And we could actually drill into the model here and find these areas where it was cheating. It's not looking for pneumonia. It's looking for annotations in the image. So to even drill deeper into that mathematics behind weakly supervised object detection, our follow-up study, which is done with our collaborators at the National Taiwan University, wanted to look at the same problem of weakly supervised object detection, but go straight back to computer science. So this is a computer science data set called MS COCO. It's from Microsoft. And we trained a weakly supervised object detector, which is the SSD300, and the standard classification network, the ResNet50, to detect people in photos. And we found, and to me, this is the perfect example of the problem, that the standard classification network labels this photo as being a bucket, and the object detector correctly recognizes the child. And on average, across multiple trials, the difference between doing weakly supervised object detection or classification is about 11 points of accuracy. And so, though the weakly supervised object detection facilitates using cheaper data, at the same time, you take a notable hit to your ability to accurately detect things. So how do we solve this problem? This is our most recent research, which is unpublished and is being done with one of my students who's a FlexMed student. But the idea is that, can we find purely mathematical ways of doing this better? And we came up with this idea of similarity boosting. And the basic concept is, let's say you're a medical student in a lecture series, and you come to me and say, hey, which lecture should I focus on? If you had 3 speakers in a row, and let's say one girl's awesome, and the other 2 are talking on the exact same topic, I might say, hey, maybe focus on the first speaker, maybe don't pay as much attention to the next 2 because they're talking about the same thing. Whereas if you had a lecture series and every speaker was unique and kind of an expert on their field, I'd say, hey, you should focus on all of the speakers. And essentially, we're doing the same thing here for the artificial intelligence with the similarity boosting. We're weighting the gradient on each backpass per mini batch based on the similarity between the mini batches. What's super cool about this, though, is that the teacher network, which is instructing the learner on which mini batches to focus on or not, doesn't have to know the actual content of the lectures or the mini batches. We can train a teacher on Roman numerals and have it inform a learner network on fashion designs. And in doing so, we obtain a network that is, on average, about 6 to 8% more accurate, and it converges in about half the training time. Which again, half the training time, it's cheaper to train these, significantly less cost in terms of compute and in terms of data, and it's more accurate. So we're hoping that this is a purely mathematical solution to address some of our challenges in weakly supervised object detection. And so where we're going with this, my kind of theme for this coming year is neurocritical care. I think neurocritical care is the autonomous driving of the healthcare system. It's the only thing that approaches autonomous driving in terms of terabytes per patient. In the neuro ICU, we generate about 0.6 terabytes per patient or 0.6 terabytes within the ICU per day, which is the closest thing to autonomous cars, which generate about 3 to 19 TB a day. And so hopefully we can use some of these techniques that we've been developing in all these other studies to drive some novel tools in our neuro ICU. So I guess my main takeaway message, neurosurgery research requires attention to detail and a good delineation of the problem. It's highly collaborative, and ultimately all this research here is highly empirical. Even though it's fundamentally mathematics research, it's all driven by the scientific method, and at the end of the day, the theory, though it is mathematics research in some of these studies, the theory is very weak, and so the scientific method becomes imperative. I'd like to thank my team. It takes a large group to do this, and our collaborators at the National Taiwan University are integral for a lot of the pure math research. Thank you.
Question for Dr. Sherritt Klein. I'm a clinician on service, and I get the alerts, and I understand alert fatigue could be a problem. And I also have a bunch of alerts that I think are very important because I work in infectious disease, infection prevention, but I guess that there are other divisions that have other alerts that think they are very important for them for patient safety, because we all think these are very important to go forward and be an epic. So my question is, how do you decide which alerts go through? And what is the data that supports in terms of what's important for the patient? Because of course you mentioned there are regulatory alerts, there are coding alerts, there are patient safety alerts. I would think that patient safety alerts should trump everything, but how do you decide which ones make the cut? And who makes those decisions?
The red light is off or on?
It's good.
It's on.
Good.
The red light's on. That's counterintuitive. Okay, great question. We get a lot of requests for a lot of things. In some cases, requests are stratified with prioritization schemes that look at, is this a request that will not, what are the implications of not fulfilling this request? Are we going to be in regulatory noncompliance? Are we going to be in a financial danger? Is there a patient harm component to it? That's an initial stratification of the requests that we get. Within those, when you can still get to a point where you've done the stratification, and then it's a question of, well, we can only do so many things, even if we wanted to do everything, and that becomes a resource question and prioritization in terms of, well, if we do this, what are we not going to do, or what are we going to push off? So those are kind of resource and operational questions. Assuming that you want to do everything, how do you decide which of those things to do? And that goes through, like I was saying, we have a governance structure and a clinical decision support committee. It's chaired by Dr. Joseph Canry, who's done a lot of research in the area of clinical decision support, what the most effective tools, et cetera, are. But the first step of going forward is, again, figuring out what is it that you're trying to do. As an infectious disease doctor, are you just trying to create awareness? For example, there is a measles epidemic going on, right? So that came up over the past several weeks. What should we do in the medical record system to appropriately inform people? And so you could have a pop-up that says this patient is at risk for measles. But then who are you presenting that to, and what do you expect them to do about it? Giving information that is like, okay, doesn't necessarily get to the point. Putting that information in the alert system for the floor physician is already too late to tell them that this patient may be at risk for measles. They've already exposed a whole lot of people and they're not in the appropriate room. So depending on what the setting is and where you're looking to get it will guide what our decision of how to implement is. So in the emergency department, we have information going out in the triage area to the registrars and to those folks in a more intrusive way, whereas down the road, over the course of the hospital stay, we have other ways to put information as banners across the first screen that you see when you open the chart that are not intrusive in the same way, but are still eye-catching and give that information without interrupting the workflow. So everything is taken on a case-by-case basis. Everything, depending on the urgency, goes through various degrees of deliberation versus trying to fast-track things. But at the end of the story, we try to work with the stakeholders who are making the request to figure out what is the most efficacious and least harmful way to get the information that you want to get out there so that you get the results you need. I don't know if that answered it. If there's something specific that you want to build in Epic, then I'll show you the forms we need to fill out and we'll get it done.
Other questions?
When you're thinking about different approaches to alerts or different ways of getting physicians to use this information, to what extent are you thinking about consciously using choice architecture and work from behavioral economics to sort of influence that? And to what extent are you thinking of doing research on that to figure out how to best implement things that will actually move behavior of physicians in the ways that you want them to move? And then for Eric, your work is fascinating, and the neurocritical work is really interesting. I know it's still early days, but are you starting to think about the implementation science piece to think about those other kinds of issues about how the work is going to wind up being implemented?
I'll take the first answer and try to make it short. For the benefit of the rest of the audience, want to give examples of what you mean by trace architecture with this?
So creating defaults so that in different ways, in a way you're already doing it to some extent, and the alerts themselves are supposed to be playing that role, but there's a lot of work going on in being able to better understand from cognitive psychology what works best. So you have a default set up one way, so you have to force people to do certain kinds of things, and it nudges them in different ways.
Right,
So
yeah.
there's a lot of work going on in how to
Right. And there's a lot of risk there too, and that's where coercion can kind of get into a situation where the stakeholders often want forced choices to their solutions. Do not allow the ordering of this test unless the clinician answers yes to this question. Right? We see that all the time. We see it in infection disease. They can't order a test for C. diff unless you say, yes, this patient has had diarrhea for 3 days and has not had a laxative, right? But behaviorally and cognitively, we know that once the decision by the clinician has been made that they're going in there to order the test, there are some cases in which you can give information at that point of care that say, maybe this isn't the right thing for you to do, but in a huge number of cases, residents and house staff are really, really smart. They've gotten through medical school and they're here. They're going to quickly figure out what button to press in order to get what they need, and they will be gaming the system. And in a sense, while on the one hand, putting these hard stops in looks like the right way to influence behavior, the downside of it is that you're actually losing information by doing that. If I have to do something in order to move forward, I'll do that thing to move forward. If you give me a text box to explain why I'm doing this, that now lets me see, well, what exceptions to this rule did I not think of before, and how can I feed that back and give us more opportunity to educate? Another way of looking at it is we have a radiology decision support system that is universally annoying to the clinicians. I'm just looking to see if there's radiologists in the room. That before you order a MRI, which is expensive, et cetera, you have to tell it why you're ordering the test, and it gives you clinical decision support saying that this test gets a score of whatever by the radiologist as the right test for this disease. Unfortunately, the way to do that is to have a list of like 100 different reasons why you could be ordering the test, and then you get your score. So it becomes a little bit of a game of, well, if I pick this one, I get this score. If I pick that one, I get that score. And I'm forced to pick something. There's also a question of I'm in a hurry, and the way that I can't find my exact issue here. Pretty quickly you learn that head trauma is a definite yes, whereas headache might not be, and seizure might not be, and what you're looking for might not be. So if you look at your results for all the MRIs that are ordered, 100% of them are compliant with the guidelines. That's great. You can now publish that we put in these guidelines and now you're 100% compliant. Have you changed anyone's behavior? Probably not. You have the same number of tests being ordered, but suddenly they're all compliant. Well, that's because you created a system where the only way to order the test is to be compliant, as opposed to allowing getting the information of why you're really ordering the test instead of letting people get around that. You're going to say something.
I'm sorry, you're studying like what works for being able to move behavior.
Yes. So we then look, so again, with that, you look now and see, did you get your outcome? Your outcome was not to get people to check boxes with the MRIs. Your outcome was, but this is such a higher level of looking, and the effort to do that, people want the alerts to go in, but the follow-up of it is really hard to do. First of all, it's actually not, you have to do such manual work to then see, well, they checked the right box, but did they really mean it? How do you get to that other than someone really reviewing the chart and figuring out what was the true reason they ordered the test, et cetera? It's tricky.
Maybe I can ask before you jump in. Do you actually do controlled trials of which path and which method works?
sort of like A/B studies
Yeah.
where you put this
Yeah.
in, you put
I think
this
that's
in.
what you were asking.
So for the decision support, we did do that explicitly. There was an IRB approved randomized trial where in the ambulatory setting, the decision support was turned on for a certain group, not turned on for another group. That was done in collaboration with MIT. Data collection's ongoing with that.
Yeah, I was going to say sort of the same point. I think controlled trials are essential for these technologies. This is an anecdote. One of my friends is the CEO of a startup, and they do like a radiology decision support tool to accelerate radiology workflow, and it's to identify strokes. And so they wanted something that's very sensitive because you don't want to miss a stroke. And what they found the unintended consequence of that was, though, a lot of normal studies were getting called as having strokes, and the radiologists would second guess themselves because if the machine says there's a stroke, I need to look again. So it actually led to a significant deceleration of radiology workflow.
One last note on the clinical trials. With a drug, you're not allowed to give the drug until you've gone through the clinical trials and proven that it worked. With clinical decision support, nobody is stopping you. Telling someone who says, we need to stop these C. diff tests, we're over-testing for C. diff, we need an alert to go now, and saying, well, you know what, let's study whether these alerts are going to work before we do it. Let's come back to you in 6 to 8 months, and then we'll decide whether to put the alert in. That response doesn't go well with leadership to make that happen. And the ethical considerations too. Does the MRI alert to stop you from ordering an MRI when someone might have a metallic implant? If you end up in the control group for that and the lawyers ask you later, you know, those 40 patients all had an alert that popped up. Why didn't my patient get an alert pop up? Oh, we're still studying that and we didn't do it. You know, you could have turned it on for them and you didn't is a little harder to defend than, well, we didn't give this drug because it wasn't proven yet.
Other questions?
There was...
No, he did. Rosamond, you had your hand up?
Okay. Sure, thank you. I guess this is more for Eric and, I can't see what I wanted to say. I guess Eric and Scott. The issues having to do with patients. So in liver transplant and liver disease, you want to see for research an extra biopsy, or you might want the use of the explanted liver. And in neurosurgery, you certainly want to see samples and evidence from patients. Now, in liver transplant, patients really, except for New York perhaps, have very limited access to places where they can get treatment. So they really want their doctors to think well of them. So the doctor asking, can I have your biopsy, can I have your explanted liver, puts some degree of pressure on the patient to want to please their doctor as well as be a nice guy. Is there a problem in asking patients to participate in letting you have their extra sample, their biopsy, or even their electronic information from the EMR?
Well, the last answer is easier because I think patients are entitled to their healthcare information. The first question, so we do that all the time. We ask for an extra biopsy for a study or use of the explant. Those are, tightly governed by Glenn Martin and the IRB in terms of what are the appropriate. So I'd actually, in a way, toss the question to him because I think the implication is it coercive in a way when a patient is desperate to get treatment or want to be well thought of to ask them for biopsy? And even if you have IRB approval, which is necessary, is that removing the coercion from them wanting to be compliant? And I don't know the answer, Rosamond.
Well, there are philosophers in the room, so I can say that we usually think that coercion involves a threat of harm. So for the most part, when you ask somebody to take your survey or be in a study, there is no obvious threat of harm. But in the patient's mind, when there's only one transplant center or only one place that does this kind of brain surgery, they have no alternatives. So if they get their doctor to think less well of them. There is an implicit kind of threat of harm in there. So should we be asking people to participate in research?
Gosh. Glenn, you want to contribute to it?
Well, yeah, I mean, generally the IRB's position is that everyone understands the difficulty of having the person who is the treating doctor asking for research permission simultaneously for the reasons that have been asked, and where we can, we try to avoid.
Thank you. Other questions? Anyone? Where the microphones are.
Dr. Klein, you talked about best practices in several different places in your talk. I'm wondering, how do you know what a best practice is?
That's a great question. You know, they call these best practice alerts even in the medical record system. There's a section for BPAs. Pretty good practice alerts didn't pass the name test, but we rely on subject matter experts typically who work. We seek them out and work in collaboration with them to weigh in on requests for alerting. When we design, when we get requests for order sets to be designed, we always try to include a link to, we can include a link to literature if it's a treatment guideline that is a published guideline that we can do. But many things that fall under a category of best practice alerts are often just alerts without evidence to say that they're the best practices. They're stuff that, that we have come up with reactively towards a situation that we see arising that we want to change then and there. And often that leads to the development of the best practice by, again, seeing whether the outcomes to the intervention yield good results.
That's sort of a reverse engineering of best practices, isn't it?
Sometimes.
What you're saying is that a lot of best practices that you use in your system are consensus-based rather than evidence-based.
Yes.
Dan?
I have a question for Eric. You closed your talk emphasizing the fact that that your theory was weak and therefore you were dependent on good scientific practice. That's an awfully complex statement to just suddenly end on. Can you unpack that a little bit? Because there's a lot in the whole use of information science for decision making that sort of hinges on that issue.
Excellent question. I think it's not the theory in terms of the like the trial design. I think that's certainly robust. I wasn't suggesting that, but specifically for my area of machine learning is deep learning, and for deep learning and the theory of artificial neural networks, why exactly they work so well, and particularly even more importantly, why they don't work so well. It's though they arise from very simple mathematical equations. They display, I don't say emergent behaviors, because it's not quite that phenomenon, but we don't really have a good theoretical reasons for why they behave some of the ways that they do. Even though that they arise from simple equations, and in some fundamental way it's mathematics research. And so I guess, what I always tell my students is that though they're doing some cases like math research with, handwritten Roman numerals, that their kind of adherence to good, in a sense, clinical trial design and having good controls and experimental design is as important, maybe in some cases more important for the research that we do in math than some of the patient-centered research that we do, just because we don't have a really good theoretical understanding of deep neural network behavior. So that's mainly what I was driving at.
So you're not saying that the biologic, your reference to theory being weak was not to the biologic theory underlying the decision-making being weak. It's purely on the math side.
Correct.
And you're depending on good clinical trial technique to protect you from your ignorance on the math side.
Correct, which is kind of unique for math research, but also it's really exciting, I think, and one of the areas that makes me love this area of math research so much.
Robbie, you had a question?
My question's for Dr. Orman. As you kind of showed in your talk, neural nets, deep learning, sometimes these models can cheat, and they can be a bit of a black box. And so as you see deep learning making its way into all aspects of clinical care in the future, what type of governance is needed to make sure, as we partner with folks from industry and the different ways that deep learning will make itself into the clinical, care delivery systems, how do we have a level of governance to ensure we kind of understand what we're implementing?
I think it's a great question. It's definitely actively being investigated, by the FDA, for example. They released those new guidelines, which, the new guidelines, I haven't read all of them in depth, but I know they do very much focus on the methods of development. And I do think that to someone experienced in the research area, you can look at the methods and specifically looking at the methods of development, and if they sort of adhere to those good clinical trial design principles, in some ways, even though, again, you're developing on the math side of things, not even the validation, that you can get a feeling for how robust they might work when they encounter the real world. But I really do feel like they should, especially when used in clinical practice, we need to evaluate them like we'd evaluate any other kind of pharmaceutical intervention. Like, strong trials, especially randomized controlled trials, are necessary since we really don't have good theory. On the computer science side of things, though, definitely the theme and research for the past 2 to 3 years has really been a push towards making these models more understandable. And I think in specific sub areas, especially with the computer vision stuff, we've made some big strides. And then in the more broad sense, I think, especially out of Technion, there's been some great research at using formal information theory to try to understand the networks. I'm hopeful that will lead to some traction in the coming years.
So we have about 3 minutes left. I'm going to take the prerogative of asking my own question or two, and then if there's time, maybe one more from the audience. So actually, one question for the two of you and one statement for Avi. So just as a play on words, the learning healthcare system, I know what the intention of this conference is, but the other thing that I find very interesting is that the big difference between the electronic health record and what we used to do in the past, which is write in a paper chart, is that there's an opportunity, and it happens every day, for the provider to learn from the system. And the more sophisticated it gets, it's not just learning that to remind me that I need to give everybody a flu shot, but these pop-ups come up or links to data. And so this is not a question, it's a statement. I haven't seen yet that people have linked the work that we do on an EMR to CME credit. That, for every 50 pop-ups that I actually click on, I get a CME credit. And I wondered to what extent that would motivate, incentivize people to look more carefully and spend more time using it in the way in which we intended. So that was a statement. The question I have for Scott and Eric is, Scott, you presented a lot of information about, and you didn't go into a lot of detail, I understand, about sort of concerns about the animal models and research in general. So if someone like you were sitting with someone like Eric and had beer to talk things over with, is it possible that the kinds of things Eric mentioned having to do with massive amounts of data that already exists, algorithms and equations, could to some extent replace the need, maybe not entirely replace, we don't want to entirely replace radiologists, but we might replace a lot of them. We don't want to entirely replace animal model research, but is it possible, Eric, Scott, that the kind of work you're doing now, this deep learning, could replace a lot of animal model research that we have historically done, because a lot of data exists in terms of the way they respond to different, et cetera?
The short answer, and Eric probably has more depth of understanding, is it's being done already. And so increasingly, pharmaceutical companies are looking to predictive models, also for enriching. So in addition to trying to supplant animal models, they're also trying to extract information from clinical trials to see which would be the best patients to try in the next trial, or which are the subgroup of patients that are best modeled by a neural net or machine learning. So, and there's also platforms now for what are called liver on a chip, for example, and I'm sure this is done with other organs as well, where you can integrate clinical information to try to replicate the key elements in a platform, basically in a scaffold. So the absolute answer is yes, and I think we'll see more of that. And it's faster, and of course it's safer.
Right. So Eric, from your perspective, what's the best case scenario, taking this out 10 years into the future, and is there an Armageddon ethical scenario in your mind?
I mean, I think to echo what Scott said, I think certainly in the pharmaceutical industry, like this is happening. But I think the goal is not to completely, because I don't think you can completely eliminate animal research or human research, but it's to reduce the need for it, reduce the scale for it. You know, suddenly, rather than running these large-scale animal studies or screens or human studies or screens, suddenly it's just kind of a quick check at the end that, oh, this actually works in the biology, this actually works in the human cohort. And I think that's sort of like the promise of incorporating machine learning into trial design.
And Armageddon?
And I do think we're going to see increase. So I'm sort of answer to Professor Magnus's question. I think the real value add from artificial intelligence techniques is in full automation, and that without full automation, in a lot of use cases, question how much value is added. But I think the processes within medicine that we can fully automate will be ones that we want to see automated. So I don't think Armageddon, but actually I really think that hopefully, my hope always as a researcher is to spend less time with my computer, ironically, but more time with my patients. And that's really where I see hopefully the value add from these techniques.
Thank you very much. Thanks everyone for coming.